Hey guys, this week we are going to learn about joints, which are also called articulations. Those two words are interchangeable, so make sure that you know that articulations and joints mean the same thing. Articulations are where our body movement occurs. So your knee is a joint where flexion and extension of your leg occur. Your hips is where flexion and extension of your hip occurs, right? So these joints, the elbow is flexion extension of the forearm. So all of our body movement takes place at our joints where two bones are being connected together. Joint structure is determines the direction and distance of movement. So how far can a joint move? How much can a joint move? If you think about the carpals that we just learned about, they're very short bones and they have very small range of motion versus the shoulder, which has almost 180 degrees of rotation. And that's all because of the distinct shape of each of the different joints. The very important thing to know and to remember here is that the strength of the joint decreases as the mobility increases. So we have a trade-off there. So you can't have strong and mobile joints. So your joints are either strong and have limited mobility, or they have great mobility and therefore they are weaker. We have two ways to classify our joints: by the functional classification, which is based on the range of motion, so how much does that move, or by their structural classification, which is what do their physical anatomy look like? How is that joint organized? So we're going to look at them each way. So on this table, you can see, and this is straight out of your book, so you can look these up. We're looking here, if you look right up here, it says synthrosis. So that's our functional category, which is the synthrosis is a joint that does not move. And then up here, you see our structural category. So the functional category of this entire slide is synthrosis. So we're looking at joints that do not move. And then we have multiple sub-classifications under structural category. So let me erase those. All right, so our first one is a fibrous joint, and the fibrous joints are our sutures. So remember we learned about our sutures, and you can see this is the back of a skull. So the arrow is pointing to the sagittal suture, and then you can see the lambdoidal suture with a little Wormian bone on the right side there. So sutures are a synarthrosis, meaning they don't move much, and they are connected by dense fibrous connective tissue. So that's what makes them a fibrous joint. So they would be categorized as a fibrous synarthrosis. The second one down, I'm sorry about the wind if you guys can hear that, it's very windy outside. The second one down is called a gomphosis, and this again is a fibrous connection, but the gomphosis is where teeth are bound into the sockets, into those alveolar processes in the mandible and the maxilla. So a gomphosis is where a tooth is connected into bone. It is a fibrous connection, what is the periodontal ligament that actually connects that tooth into the underlying bony tissue. The third one down is a synchondrosis, and that's a cartilaginous connection. So you can see here that you've got the bone on this side and the bone on this side, and then this rim of cartilage in between that's connecting them together. So this is where the ribs are coming into the sternum. So that would be the first rib coming into the manubrium, and then the second one coming down into the body of the sternum. So it's a cartilaginous bridge between two bones. It's a synchondrosis, and there's very little movement there. And then last we have this bony fusion, which is called a synostosis. So remember when we were learning the bones of the skull, we learned the frontal bone, and that it has the metopic suture, where the two sides of the frontal bone have come together and fused in the center, and sometimes there's a suture, a line there, which is a bony fusing. And so a synostosis is fusion of bone. So there's no cartilage in between, there's no fibrous connective tissue in between. It is just two pieces of bone that have bound together and leaving an epiphyseal line. So in our long bones, right, we have the epiphyseal plates while we're growing, and then when they fuse, they leave epiphyseal lines. So those epiphyseal lines are actually also considered a synostosis. So now, if you look up here, our functional category has just changed to amphiarthrosis. So amphiarthrosis is a joint that has some movement. Not a lot of movement, but a little bit of movement. So it moves more than the previous one, but not as much as a diarthrosis. So the amphiarthrosis, let's see, this gives more movement than a synarthrosis, but is much stronger than a freely movable joint. So remember, as we get more movement, we become less stable. So these have a little bit more movement, but they still provide great stability. So the first one, so we have a fibrous category and a cartilaginous category. In the fibrous category, we've got the syndesmosis first. A syndesmosis is where bones are connected by a ligament. So it's just a ligamentous connection between bones. So here they're showing you the articulation between the tibia and the fibula. You could also look at the interosseous membrane or ligament between the radius and the ulna. That would be considered a syndesmosis. And then our symphysis joint here is where there is a fibrocartilage pad in between the two bones. So this is showing you the pubic symphysis as the example. So you have a fibrocartilaginous pad where the two fronts of the pubic bones or the pubic tubercles come together. And so it allows for some movement permitted in the front of the pelvis. Another place that we see symphysis joints is at the intervertebral joints within the spine. So you have the discs in your spine, intervertebral discs, and those are fibrocartilaginous pads. And so they are making up these symphysis joints all the way up through your spine. All right, our last functional category is the diarthrosis. So you can see that up here, our diarthrosis, and those are our synovial joints. So the terms synovial joint and diarthrosis and freely movable joint are all interchangeable. So a diarthrosis is a joint that has full ranges of motion. And they are broken down and they're surrounded by a synovial membrane. So we have a synovial capsule around these joints. The joints are bathed in synovial fluid, and they have lots of movement. So synovial joints are broken down into three categories: monoaxial, biaxial, and triaxial. So monoaxial means they move within one plane. So the elbow does flexion and extension. The ankle does dorsiflexion and plantar flexion. So those are coming up toward the ceiling and pointing down toward the floor. So that's movement in one direction. Biaxial joints move in two planes. So the ribs move superiorly and laterally. And the wrist, with your wrist, you can do flexion and extension, and you can do medial rotation and lateral rotation at the wrist. And then our triaxial joints move in three planes. So our shoulder can flex and extend. We're going to learn all these movements later today. So I'll wait. I'm going to wait on that until we get into the movements. But the point here is synovial joints surrounded by a joint capsule, bathed in synovial fluid, and they are categorized based on the amount of movement. Monoaxial moves in one plane, biaxial move in two planes, triaxial joints move in three planes. So we're going to look a little more deeply into synovial joints. So here we have a picture of a synovial joint. You can see that this top bone here, this would be the diaphysis, and then here's the metaphysis, and here's the epiphysis. And then if we delete those, down here at the bottom where you see this nice light blue, that's our articular cartilage. Do you remember how we were talking about the development of a long bone, how it begins from a cartilage, a hyaline cartilage model, and then the arteries are going to permeate into the bone, fibroblasts are going to become osteoblasts, and it's going to start ossifying that bone. As that bone grows and matures, it all turns into bone except those tips, which remain that hyaline cartilage model. And those are what give the joint nice cushioning. So we have that cartilage within the articular capsule. So we have this fibrous joint capsule, which you can see out here. That's our joint capsule. And the capsule and the cartilages are what keep the bones from touching. The bones, if they were just bone on bone, bone is a very harsh, solid matrix. It's 99 or whatever, no, it's actually 66% calcium salts, 2/3 calcium, 1/3 collagen, right? So our 2/3 calcium is really rough and rugged. And so if bone is rubbing up against another bone, it's going to break down the surfaces really easily. So our cartilage is really protecting our bones from one another. The capsule also is going to secrete synovial fluid. So the fluid, the whole joint is bathed in fluid, and it helps to reduce the friction between the bones, the friction between the cartilage, and it also gives a little bit of cushioning to the joints as well. All right, so our fluid is a slippery substance. It's made up of proteoglycans, which are secreted by fibroblasts. And the function is to lubricate the joint. You remember a nutrient distribution. So you remember that cartilage is avascular and it needs to take up its nutrients through diffusion. And so it's being that all those nutrients are being diffused through the synovial fluid into that articular cartilage. It is also for shock absorption. So when you're running and jumping, it's giving you some of that absorption of those impacts instead of transferring them directly through your bone, which could become potentially painful. We have some accessory structures as well. So we have fibrous cartilage pad in some joints, which is the meniscus. So we have a meniscus in our knee. We have a fibrocartilaginous pad in our wrist. We'll learn more about specific joints in a little bit. We have fat pads, which are outside of the joint capsule. The meniscus is inside of the joint capsule, so it's intracapsular. The fat pads are extracapsular. They're outside of the joint capsule. And so we can see here in yellow, maybe I should do that another color, in blue there, that's that yellow there is the fat pad, and that's giving some cushioning and protection to the joint. And then we have ligaments which strengthen and stabilize the joints. They're crossing from one bone to the next. They're keeping everything nice and sturdy and stable. Little vocabulary here. A sprain is when you tear the collagen fibers within a ligament. A sprain with a P is when you tear fibers within a ligament. A strain with a T is when you are tearing muscular fibers. Oftentimes they're diagnosed as a sprain strain because it's not always easy to differentiate just symptomatically which structures have been torn, but to be specific, a sprain with a P has to deal with ligaments, a strain with a T has to deal with muscles. Couple more accessory structures. We have tendons, which are attaching muscles into the bone around the joints. In order for a muscle to affect the joint, it must cross over that joint. So you can see here that the quadriceps tendon is attaching the quadriceps muscle into the patella, and then the patellar ligament is connecting the patella down into the tibia. And then last but not least, we have bursa. And a bursa is a pocket of synovial fluid that is surrounding the joint, and it cushions areas where tendons and ligaments might rub together. So they traditionally have a very small amount of synovial fluid in them. Sometimes they get inflamed. Sorry about that. Sometimes they get inflamed, they fill with more synovial fluid, and they become very irritated. And that's when we get what's called a bursitis. They're located around most synovial joints, in between tendons and ligaments, superficially between the skin and the bone. They're really for protection. So in this picture, you can see this bursa right here. You've got one here in front of the knee. You have two more down there. There's a whole bunch of bursa around each joint. And they're very, very helpful in making sure we don't want our tendons and ligaments to stick together, because then we will lose range of motion. So we need our joints to be pretty stable. If you have two bones that just came together and there were no accessory structures, nothing would hold them together and your bones would just fall apart. So we need lots of different things to keep them stable. So some of the factors that stabilize our synovial joints are collagen fibers. Remember, collagen fibers are stronger than steel when strained in one direction. So if you pull them from end to end, they're stronger than steel. So our joint capsule is made up of collagen fibers. Our ligaments and tendons are made up of collagen fibers. The articulating surfaces, the actual shape of the bones, can have a great effect on the amount of range of motion. And so sometimes the shape of bones limit the range of motion and stabilize that joint. Menisci, which are those fibrocartilaginous pads in between. When you lock your knees, you are pressing those menisci in between your tibia and your femur. And that's what's really locking your joint together. So they're giving stability so you can't hyperextend your knees. Other bones in the area, muscles surrounding the joint, fat pads are protecting us. Tendons of articulating bones are also crossing over that joint and giving added stability. Even though we have all that stability, we do still injure our joints. So some of common injuries are dislocation, or a luxation is where you completely lose contact between the two articulating surfaces. So if you were to dislocate your knee, you would lose your contact between your tibia and your femur, which is, I can only imagine, extremely painful. When that happens, you're going to damage the cartilage, you're going to damage the ligaments, you're going to damage the joint capsule, you're going to damage the menisci. Everything in there is going to get damaged when you totally lose contact between the two bones. A subluxation is a partial dislocation where something is slightly out of place, so not where it really should be, but it hasn't completely torn all of those other structures. I do like to point out on this slide that in chiropractic, we use the term subluxation, and we use it differently than the traditional medical practice. So in traditional medicine, a subluxation is a partial dislocation. In chiropractic, we use the term subluxation to describe a joint that has lost its full range of motion. And that's a very important distinction, because people often go to the chiropractor and they say, oh, they told me I have a subluxation, so I need to put my bone back in place. And that's not really what chiropractic is about. It was the original model that was easy to explain to lay people, but it's really about looking at joints that have lost their mobility and then putting small forces in through those joints to restore that lost movement. All right, so we're going to move on to joint movements. And so we talked about the classification of joints, how some of them are very strong but not very movable. Some of them are extremely mobile and therefore much weaker. And so we talked about monoaxial, biaxial, and triaxial. synovial joints, and so we're going to look at what are those different three planes of motion, or three axes of motion. So we have linear motion, which is gliding motion, angular motion, and rotation. So here we're going to look at linear motion, and you can do this at home, practice with your pencil. If you were in class right now, I'd make you do it all on your papers. You'll see that my paper actually has a whole bunch of drawings all over it. So you put the tip of your pencil down and keep your pencil so that it is perpendicular to the page. And you can either go forward and backward, or you can go side to side. And that's your linear monoaxial movement. If you were just going forward and backward, that would be monoaxial. If you were just going side to side, same thing, monoaxial linear movement. That is also called a gliding movement. Now we've got some angular movements. So in this first one over here, we're looking at keeping the tip of your pencil in one spot, but then angling the shaft of your pencil in different angles from the paper. So that's angular movement, is you're coming from horizontal this way all the way over to being horizontal that way. So that's one long range of angular movement. All right, circumduction, you are keeping the tip in one spot, but then moving the entire shaft of the pencil around like this. So the pencil is coming out toward you and then going back. So picture that being a three-dimensional circle. So the entire shaft of the pencil is moving while the tip is staying in the same place. And that is different from rotation, because in rotation, your pencil is staying upright the whole time, and you're just rotating the shaft of the pencil on the tip there. So there's a difference between circumduction and rotation. If you think of it in ideas of a body movement, if you put your arm out to the side, and I do want you to do this with me because it's easier when you move your body, I want you to make a big circle with your elbow. So you're holding your arm way out to the side, and then you're going to bring it forward, up, back, and down. That is circumduction, because your shoulder is the tip of the pencil, and then that your hand is moving, you're making a circle with your hand. So it's circumduction. Rotation, you would hold your arm straight out, but not move your arm and just turn your palm down and then turn your palm up. And so you're rotating around this one axis, but you're not moving the position of your arm in relation to the position of your body. So hopefully that helps you a little bit better understand the difference between circumduction and rotation. So we're going to look at planes of or direction of motion with synovial joints and the relationship between the structures that are within the joint. Linear motion, which is gliding motion that we just went over, is where two flat or nearly flat surfaces are sliding past one another. So this is what takes place at the carpal bones and the tarsal bones. If you picture the carpal bones, they are small, kind of squarish bones, right? They're those little short bones, and they have generally flat surfaces on either side. And so you can kind of grab one carpal in one hand and one carpal in the other hand. You can just barely glide them past one another. So that is our linear gliding movement. It's a very small amount of movement at those joints. Angular motions are flexion, where you are decreasing the angle between two articulating surfaces. Extension, you're increasing the angle between two articulating surfaces. So the articulating surfaces are the bones. So if you consider the arm, if we look at these as movement from the elbow, bringing your hand towards your shoulder is flexion. Bringing your hand away from your shoulder is extension. Abduction is moving your arm away. So if your arms are outside of your body and you're lifting them up so they become horizontal, that is called abduction or abduction. Adduction or adduction would be bringing them back down. I always remember adduction as you are adding your arm back to your body. So adduction, adding it back. Circumduction, making that circular movement that we just talked about with the shoulder. Rotation is rotating around a single axis. Pronation and supination, these are only used in reference to the wrist. You have to do this in anatomical position. So if you bend your arms, so like your palms are facing up, like you're going to be carrying a heavy box. That's the position I want you to be in right now. If you turn your palms toward the floor, that is called pronation. So if you were just in anatomical position, your palms would be facing backwards. So they're facing behind your body. That's pronation. Then if you turn your palms facing upward, that's supination. And you can remember that, like if you want to hold a bowl of soup, you need to supinate your hand. So if you're in anatomical position, your palms are facing forward. But if you have those elbows bent, supination, you're holding the soup. Pronation, you dump the soup on the floor. So here's some pictures to describe what we were just talking about. So over on this side, we've got flexion and extension and hyperextension of the wrist. So flexion is bringing the hand toward the forearm. Remember, we're bringing the articulating surfaces closer together. So that's flexion. Extension would be sort of bringing the arm to just past neutral. And then hyperextension is really bringing your arm back, or your wrist, your hand back past that neutral normal position. So flexion, extension, hyperextension at the wrist. And then we're also showing those same ones here at the hip. So flexion is bringing the leg forward, so you're decreasing the distance between your leg and your body. Extension is standing straight, so your joint at the hip here is extended. And then hyperextension is bringing your leg backwards. Flexion at the elbow is bringing your forearm towards your shoulder. Extension is bringing it away. And then if we're looking at the head, extension is kind of this neutral position here. Flexion is bending your head forward. Extension is bending your head backwards, so you're looking up at the sky. This is a rough video. If you are interested in watching terrible injuries, totally go watch this video. In class, I usually show a video at the end of this lecture about all these different, just Google like 10 worst sports injuries, and you're going to see all kinds of joint injuries that are incredible. So if you're faint of heart, don't watch this video, but if you want to see somebody totally hyperextend, dislocate the knee, this is the video for you. All right, here she's demonstrating angular motion. So abduction over here is bringing the arm away from the body, and then adduction would be adding it back. Same with the leg. Taking it away, abduction, abduction, adding it back, adduction. With the hand, you can adduct and abduct the fingers. So abduction would be spreading the fingers apart over on this side, and adduction would be adding the fingers back together. And here she's demonstrating circumduction. So her shoulder is staying in one place, but she is making this big circle with her hand. So that is circumduction. Some rotational movements. We can rotate the head to look over our left shoulder, which would be left rotation, or to look over our right shoulder, which would be right rotation. And then with the arm, we can laterally rotate. So that would be if you're in anatomical position and you are like supinating your arms, that would be lateral rotation. And if you are bringing them in so your palms are facing backwards, that would be medial rotation. Lateral rotation is also called external rotation. Medial rotation is also called internal rotation. Pronation and supination we talked about. Pronation is, so if you're, see he's got his elbow flexed a little bit here. So instead of showing this in anatomical position, he's showing that if you turn your hand so your palm is facing up, you are supinated. If your palm is facing down, you are pronated. When we get to the feet, we have a few special movements. Inversion is twisting your ankle so the sole of your foot faces inward. So if you were to roll your ankle and you could see the bottom of your foot, that would be inversion, and that generally strains the lateral side of your ankle. Eversion is the opposite, so turning your sole and your foot outward. So if you were to roll your ankle and hurt the medial side of your ankle, that would be an eversion injury. And then you have dorsiflexion and plantar flexion. Dorsiflexion is flexion of the foot, which would be bringing your toes up toward your shin. And then plantar flexion is the same as extension of the ankle, which would be pointing your toes down toward the ground. Oops, sorry, I didn't mean to switch that slide so quickly. In the hand, we have opposition, which is bringing your thumb and your pinky finger together, and then reposition, which is opening your hand back up. You can also protract and retract. So if we're talking about, let's say the scapula, that's an easy one to kind of consider. If you're standing in anatomical position and you pull your shoulders forward, that's protraction. You're bringing them anteriorly. And if you try to squeeze your shoulder blades together in the back, that's a retraction. You're bringing your shoulders posterior. Elevation in the shoulder would be shrugging your shoulders up to your ears. Elevation. Depression would be pulling them back down. So elevation, you're moving superiorly. Depression, you're moving inferiorly. And then lateral flexion is only used in relation to the vertebral column because it has to be in the midline of the body, and then you are tilting your head to either side. So you're either tilting to the left, bringing your left ear towards your left shoulder, or you're tilting to the right, bringing your right ear towards your right shoulder. That's lateral flexion. You can do it with your neck, or you can do it with your lumbar spine as well. So here's some pictures of those. Inversion, you can see here is, I wonder if I did that in green. Yeah, black just doesn't like this. But inversion on this side, you can see that the sole of the foot is pointing sort of up, medial and up. Eversion, the sole of the foot is pointing outward. Dorsiflexion, your foot is coming upward. Plantar flexion, you're pointing your toes like a ballerina. Opposition, you're bringing your thumb and your finger together. Reposition, you would be bringing them back apart. Here she's showing these special movements with her jaw. You can do that as well versus the shoulder that I just discussed. So with your jaw, protraction would be moving your jaw, like sticking your jaw out. So sticking your jaw forward would be protraction. Pulling it backward like that would be retraction. Depression is bringing your jaw down or opening your mouth. Elevation is bringing your jaw back up or closing your mouth. And then here you see her laterally flexing. So on this side, she would be laterally flexing to the right side of her body. And this is left lateral flexion. So those are, that's an F. Shorthand is LLF for left lateral flexion, RLF for right lateral flexion. We're going to talk about synovial joint types now, and these are by the shape of the joint. So this is on page 73 in your textbook. The first type is a gliding joint. So a gliding joint, and you'll see that here, this is where the classification is. So we have a gliding joint. It is non-axial or multi-axial, but the movement is slight. That's very important, that it is slight movement here. Some examples over on this side are the acromioclavicular joint and the claviculosternal joints. That's what they're showing right here, is this claviculosternal joint. Intercarpal and intertarsal joints, so the joints between your carpal bones and between your tarsal bones. Vertebrocostal joints, where your ribs come into the spine. And then your sacroiliac joints, which is two big bones bound together with a very limited movement. Second, we have the hinge joint. The hinge joint is monoaxial, so it's moving in one plane, which will be generally flexion and extension. So for those, the example over here is the elbow. So we have the ulna, which is flexing and extending over the distal humerus here. It is monoaxial. And so our examples are the elbow joint, the knee joint, the ankle joint, and the interphalangeal joints. So those are the joints in between your long bones and your fingers. Remember, those are your phalanx. So you have a proximal, medial, and distal phalanx, or proximal, middle, and distal phalanx. And you have joints in between, and you can flex your fingers to make a fist, and you can extend your fingers nice and flat. So that's monoaxial flexion and extension at the interphalangeal joints. Last, we have a pivot joint. Remember, pivot is where you are pivoting around a set point in a single axis. So rotation is the one mono axis of a pivotal joint. And the atlas axis, or C1, C2, is a pivot joint where you have the transverse ligament in the back wrapping around the Dens process of C2. So C1 can rotate freely around C2, and that's what allows you to shake your head no. Remember, nodding your head yes comes from the articulation of the occipital condyles onto the condyles of the atlas. The proximal radial ulnar joint, remember proximal is closer to the attachment, so it's the radial ulnar joint at the elbow, is also rotation, and that rotates while we are pronating and supinating. Ellipsoid joints are next here. So an ellipsoid joint is biaxial. Say that 3 times fast. That's challenging. The radiocarpal joint is a biaxial joint. The metacarpal phalangeal joints. So remember, the metacarpals are these bones out here, the distal bones. So we have carpals, metacarpals, and then phalanges. So the carpal and metacarpal joints are biaxial because at those joints you can flex and extend, and you can abduct and adduct. You can't abduct and adduct at the interphalangeal joints, only at those metacarpal phalangeal joints. And then again at the metatarsophalangeal joints, you can flex and extend, abduct and adduct your toes. Saddle joints are a little bit different. If you look over here at this picture, this looks like a dude sitting on his horse, right? You can picture this as a saddle. So the horse is like that. That's a really awful horse. I'm just going to delete that all right now. But try to picture that. So you got a guy sitting on a horse. So this is a saddle joint. It is also biaxial because it you can bring these apart and together, and then you can also come forward and backward and go left and right like that. So these are biaxial saddle joint, and the first carpo-metacarpal joint. So between the trapezium and the metacarpal of the first digit, so the first metacarpal, is a saddle joint. And then last we have our ball and socket joint. So the humerus, where it articulates with the scapula at the shoulder, is a ball and socket joint. It is triaxial. It has full movement in all 3 ranges of motion. And we have two joints like this, the shoulder joint and also the hip joint where the femur comes into the acetabulum of the coxal bone. That is another ball and socket joint. So reiteration that a joint cannot be both mobile and strong. It has to be either strong and immovable or slightly movable, or it can be freely movable but weak. When we have those mobile joints, like the shoulder is the most mobile joint in the body, and it's supported by a bunch of small muscles, also surrounded by a bunch of bigger muscles. There are lots of ligaments that are holding it together, but there are no bone-bone connections in the shoulder especially. You can pull a shoulder like humerus right off the body. So there's nothing bony holding it together there. Okay, we're going to move on to the spine, which you might imagine is my favorite thing. So C2 to L5 vertebrae articulate in two ways. They articulate at the inferior and superior articular processes, which are gliding joints. So remember, those are the little flat facets that stick up from the posterior elements of the spine. You have the superior articular process that sticks up and the inferior articular process that sticks down. And then again, they also articulate between adjacent vertebral bodies at the disc, which is a symphysial joint. It is a symphysis. So here's a pretty picture for us. We're going to talk a little bit about the discs here. So you can see here's one vertebrae, here's another vertebrae, and this is the disc in between. And it's like that between every single vertebrae from C2 to L5. The discs are fibrocartilaginous pads. They are made up of two layers. So the outside are layers called the annulus fibrosus, and those are tough fibrous layers, and they're what attaches the disc to the vertebrae. So if you were to look at it, say you were to cut this through here and look down on it, it would look like this really thick ring of tough fibers on the outside. That's the annulus fibrosus. And then the inside is called nucleus pulposus, and it's this like jelly-like core. And you can see it here depicted in yellow. So it's really gelatinous, and so that's where the shock absorption comes in. So the annulus fibrosus is the tough outer layer. It's holding everything together, and the nucleus is this nice gel layer in the middle that moves when you move. If you flex, it moves backwards. If you extend, it moves forward, and it really gives you the ability to move in so many different ways, which is pretty cool. All right, so the symphysis or symphysial joints are between the two vertebrae and the disc. So I already kind of just talked about this, that the nucleus pulposus shifts its position during flexion and extension, and that the change in the disc, the shape of the disc changes to conform to the movement that you are making. They bind the vertebrae together and give stability and lots of shock absorption to the spinal column or the vertebral column. Now we have lots of ligaments that connect our spine together. We definitely don't want our spine falling apart because it houses our spinal cord, which transmits all vital information to and from our body, from our spine and our brain. So the first one is the anterior longitudinal ligament, or the ALL. The anterior longitudinal ligament is on the anterior surface of the vertebral bodies. So if we're looking at this, this is anterior and this is posterior, right? Because we have the spinous processes in the back. So the anterior longitudinal ligament is on the anterior side of the vertebral bodies, and it's running all the way up the spine. The posterior longitudinal ligament is back here. So it is on the posterior side of the vertebral bodies, which means it's also in the spinal canal. So that's important. So the ALL, and that's the PLL. So the ALL is all along the front of the spine of the vertebral bodies, and then the PLL is along the posterior margin of the vertebral bodies within the space of the spinal canal. The ligamentum flavum, which you can see here, is right there, and it connects the vertebrae together from one lamina down to next lamina. So it's lamina to lamina. So it's on the posterior portion. Remember, if our vertebral body is here, then we have pedicle, pedicle, lamina, lamina, spinous process, transverse process, transverse process. Hopefully that rings a bell to everybody. So you've got the anterior longitudinal ligament here, and then the posterior longitudinal, posterior longitudinal ligament here, and then the ligamentum flavum would be between the lamina of adjacent vertebrae. So it would come up, up, and down, up to the top upper vertebrae and down to the bottom vertebrae. Sorry, it's not as easy to draw on this thing as it is to draw on the board in the classroom. Let's erase all that for now. So then we have the interspinous ligament, which is connecting the individual spinous processes together. So interspinous is between spinous processes. That's different. All right, so it's between, so it goes from one spinous process down to the next spinous process in that area. The supraspinous ligament is on the outside. It's very thin, and it's running over the ends, the tips of the spinous processes. So much like the anterior longitudinal ligament is around the front of the spine, the supraspinous ligament is just running over the backs, the tips of the spinous processes. So the interspinous ligament binds one spinous process to the next. The supraspinous ligament goes over the backs, the tips of all of the spinous processes. And then last but not least, we have the ligamentum nuchae. The supraspinous ligament is from C7 to the sacrum. The ligamentum nuchae is from C7 to the skull. So once you get up to C6, then that supraspinous ligament becomes larger, and it comes all the way up, and it widens out, and it attaches to those nuchal lines. We have the superior and inferior nuchal lines up on the occipital bone. So the ligamentum nuchae attaches into those occipital lines and gives you some nice flexible support for the posterior neck. You can damage intervertebral discs. This is extremely common, unfortunately. You can get a bulge in a disc. So term slip disc, don't ever use that term. I hate that term. It is not a medical term. You either have a disc bulge, or you have a disc herniation, or you have a sequestered disc fragment. But slip disc is sort of lay terms for a bulging disc, and we are no longer lay people. We are in the health industry, so we're not going to use that term. So bulge of the annulus fibrosus. So what happens is the annulus are those really firm, fibrous layers, and they can get tears in them. They get wear and tear like everything else in the body. If you're super hard on your body, if you play football, if you run all the time, if you are a Spartan racer like I used to be, all those different things can really cause wear and tear on that that annulus fibrosus, and you can get tears in them. And when they tear, that gelatinous nucleus pulposus can squeeze out and make a bulge over here. So we have this bulge there. So it's our bulging disc, and it can bulge anywhere actually really can bulge anywhere, but this would bulge laterally and potentially interfere with the nerve that's exiting the intervertebral foramen right there. They can also bulge centrally. So if they were to bulge all the way through the posterior surface, then they could press into the spinal canal and press on the spinal cord. And that gives you a whole host of different issues than pressing on a spinal nerve. We'll learn a little bit more. We're not going to go into depth in that in this course, but we are going to learn about spinal nerves and the spinal cord and all of that super exciting stuff in a couple weeks. Here's a picture of a herniated disc. So we have the nucleus pulposus, which is all in yellow here, and it has gone through those torn fibers of the annulus. So here's that picture I was trying to draw for you and doing a terrible job of earlier. So you have those nice fibers of the annulus wrapping around, and it should be encircling this nice round piece of nucleus. But instead, there's a tear. This nucleus has pushed out, and you can see that it is pressing on that spinal nerve in the intervertebral foramen, and that's going to give you pain, numbness, weakness, tingling along the entirety of that nerve. So that nerve could, from this area, it could supply the arm, it could supply the leg, it depends on at what level this is, and we can really actually utilize the symptoms of where your pain is. So like I have that herniated disc in my neck, and my pain comes down the outside of my arm, goes down my forearm, comes into my thumb and into my first finger. And that exact mapping of that pain lets me know that it's the C6 nerve root that's being pinched. And we can be very specific like that throughout the whole body, which makes diagnosis a little bit easier. At least so we can say, okay, I think you need to get an MRI so we can confirm that it is exactly what we think it is. We have specific movements within the vertebral column itself. Flexion and extension. Flexion, you're bending anteriorly, so you are bringing the body closer to the legs, decreasing the distance between the two surfaces. Extension, you're bending posteriorly, so you're bringing the body farther away from the anterior legs. Lateral flexion, you're bending to either side, and rotation, you are turning. All right, so we're going to dive now in each of the specific larger joints in the body. So the shoulder joint is also called the glenohumeral joint. It's where the humerus comes in and articulates with the glenoid fossa of the clavicle. It allows more motion than any other joint. So it is the most mobile joint in the body, and that seems like a good fact to commit to memory. Being the most mobile, it is also the least stable. So remember, it's a trade-off. You're mobile or you're stable. So this one is mobile, not stable. It's supported by layers of skeletal muscle, tendons, and ligaments. It is a ball and socket diarthrosis. We saw that earlier. And that ball and socket is between the head of the humerus and the glenoid cavity of the scapula. So here we're looking at that socket. So the humerus has been removed, and what we're looking at, this is the socket of the scapula. The glenoid labrum is just this very rim. Let me see if I can find glenoid labrum. You probably all found it before me. There it is. All right, on the bottom here. So the labrum is just this little tiny rim around the socket there. I'll delete that so you can look at it, but you can see how this blue is sort of two layers. So that very thin outside layer is the labrum. It is a fibrous cartilage, and it extends past the bone to kind of deepen the socket. It gives a little bit more contact between those two bones. So the labrum, that's also often torn. When it's torn, it's called a SLAP lesion, SLAP. And when it's torn, it's often needs to be surgically repaired. The processes of the shoulder, we have the acromion, which articulates with the clavicle at the acromioclavicular joint. So that is up here. The clavicle is here, going over to the sternum, and then here's the acromion coming from the back of the scapula. So the acromioclavicular joint is a small gliding joint. And then we have the coracoid process, which points anteriorly and laterally above the humerus, and it really helps to stabilize the joint. It kind of keeps the humerus from being able to slip forward, and it's got ligaments that are attaching into the acromion and into the clavicle. Ligaments of the shoulder, they are all named for what they attach to. So instead of memorizing every ligament, what I would like you to do is look at the names and think of like, okay, where would this be? Glenohumeral ligament. Well, that sounds like it would go from the glenoid process to the humerus, right? And that's exactly what it does. So the glenohumeral ligament, I don't even see it on here, but it would go from the glenoid fossa to the humerus. The coracohumeral ligament would go from the coracoid process to the humerus. So those are probably resected away in this picture. The coracoacromial ligament, which is here, goes from the coracoid process to the acromion process, like that. The coracoclavicular ligament goes from the coracoid process to the clavicle. So we have two of them right there. And the acromioclavicular ligament goes from the acromion process to the clavicle. So they're super obvious. They tell you exactly what they attach to. So if you can think of that, you're golden on this. Shoulder separation is a dislocation of the shoulder joint. It is the most frequently dislocated joint in the body. Often we separate the AC joint, but you can also dislocate the humerus from the glenoid process as well. Oops. Trying to erase. All right. Muscles of the shoulder joint are the rotator cuff muscles, and that is cuff, C-U-F-F, not C-U-P. A lot of lay people call it the rotator cuff. It is not a cuff, it is a cuff. Those muscles are the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. When we learned the scapula, we learned that the supraspinatus is in the supraspinous fossa, that the infraspinatus is in the infraspinous fossa, that the teres minor comes off the lateral border or axillary border of the scapula and comes around and attaches into the humerus, and the subscapularis is on the subscapular fossa. When we do muscles, we're going to learn those more in depth, but just do know what four muscles make up the rotator cuff for this week. And then the bursa in the shoulder, remember we said we have bursa everywhere. So we have a subacromial bursa, which is exactly where it sounds, under the acromion. We have a subcoracoid bursa under the coracoid process, subdeltoid bursa, which is under the deltoid muscle, and then a subscapular bursa, which is between the scapula and the rib cage. So in this picture, it is showing us the subdeltoid bursa, which is right here. All right, so that was it for the shoulder joint. We're going to move on to the elbow. So the elbow is a very stable joint. It's a hinge joint, so it moves in one plane. It is articulations between the distal humerus and the proximal radius and the proximal ulna. So you can see that here. We have a couple of different joints proximally. So we have the humeral-ulnar joint, which is here, where we have the trochlea of the humerus. You remember the base of when you look at the tip of the humerus, that distal end, you have the trochlea medially and the capitulum laterally. And then you have the trochlear notch of the ulna, which here what you're looking at is the olecranon process. Oh, where did we go? So olecranon process here, So underneath this, you've got the hinge of the ulna. So the ulna looks like this under there. So this is the trochlear notch of the ulna and the olecranon process, and then it is coming around the trochlea of the humerus. That's the largest articulation in the elbow, and it moves in flexion and extension. The humeral radial joint is a smaller joint. It's here, and it's between the humerus and the radius, so which you can imagine from the name. It is the head of the humerus that is articulating with the capitulum on the lateral side of the distal humerus. So the head of the humerus flexes in over the capitulum to the, oh, I just drew a blank. Oh my goodness. The radial fossa. The radial fossa on the anterior humerus. And then the olecranon process is going to, when you extend, is going to go into the olecranon fossa on the posterior humerus. Support of the elbow comes from the biceps brachii muscle. This is the tendon of that muscle, which comes down and attaches into the radial tuberosity. So then the biceps muscle itself would go up like that and then come and attach into the shoulder. And that controls elbow motion. So the biceps brachii, when you contract it, it flexes, it pulls the forearm up toward the shoulder. When you relax it, it allows that forearm to extend backwards. Ligaments of the elbow, we have the radial collateral and the ulnar collateral. So collateral just means on the side. We have collateral ligaments in the elbow. We have collateral ligaments in the knee that we're going to learn about. So the ulnar collateral is literally the lateral ligament on the ulnar side. So that would be on the medial side of the shoulder or the elbow. And then the radial collateral is on the radial side or the lateral side of the elbow. All right, so we're going to move on to the hip. The hip, which is also called the coxal joint, is a very strong ball and socket joint. So it is a ball and socket, which means it is mobile, and it is also strong because it is less mobile than the shoulder. Even though it has a big range of motion, it doesn't have nearly the range of motion of the shoulder, so it is much more strong than the shoulder joint. The head of the femur is going to fit into the acetabulum. Remember, this is called the lunate surface of the acetabulum, and the head of the femur fits right in there. The acetabulum also has an acetabular labrum, much like the glenoid labrum, which is going to deepen that socket a little bit. And then we have this ligament of the femoral head here, which, if you remember, is going to attach directly into the fovea of the head of the femur, and it really holds that bone tightly into that joint. That is something we do not have holding the humerus into the glenoid, but this ligament does give the hip added stability. Ligaments of the joint, we have of the hip, we have the iliofemoral ligament, which goes from the femur here up to the ilium, like that, iliofemoral ligament. We have the pubofemoral ligament, which is going to be on the other side, going from the pubic bone to the femur. Actually, that's probably here, pubic bone to the femur. We have the ischiofemoral ligament, which is going to go, that would be on the back side, from the ischium to the femur. The transverse acetabular ligament, which, if you remember, that is the one that used to be called the ligamentum teres, and it is just over that acetabular notch on the gap on the bottom of the acetabulum, the bony ridge of the acetabulum. Sorry, that's the transverse acetabular ligament that I was just discussing. The ligament of the femoral head is the one that we just discussed in the last slide, which is connecting the femoral head at the fovea and bringing it in to connect it into the acetabulum. So here's on the back side. So this is the ischiofemoral ligament from the ischium over to the femur, the iliofemoral ligament from the ilium down to the femur, like that. Okay, on to the knee. So the knee is what's called a complicated hinge joint. The elbow is an easy hinge joint because it just flexes and extends. And the bones wrap around one another to make that easy. In the knee, we have two rounded condyles that are rolling across a pretty flat surface on the top of the tibia. So it's there's not a lot of bony connection there that makes it an easy hinge joint. So that's why it's complicated, because of the rounded condyles rolling across that flat surface on the top of the tibia. So the points of contact are always changing in the knee. The knee functions to transfer weight from the femur to the tibia. So when you are standing up, the femur is going to carry your weight down and it's going to give it directly to the tibia. Remember, the fibula is not a weight-bearing bone. It is simply there for muscular attachment. So the tibia and the femur are holding all the weight of the leg and, well, the entire body. The knee allows for flexion and extension, and then some limited rotation. So that's also the complicated hinge, is the hinge would only be flexion and extension, but there is this mild bit of rotation that we can do at the knee. We have 3 articulations at the knee, 2 between the femur and the tibia at the medial and lateral condyles, and 1 between the patella and the patellar surface of the knee. So here I want to point out, and I hope that you remember it, that the patella articulates with the femur, period. The patella does not articulate with the tibia, it does not articulate with the fibula, it only articulates with the femur. The menisci we talked about earlier are those fibrocartilaginous pads within the knee. We have a medial meniscus and a lateral meniscus. So if you're looking at this picture, it's showing you that this is the lateral side. You can also tell it's the lateral side because the fibula is always on the lateral side of the leg. So this would be the lateral meniscus here. And then this side would be the medial meniscus. And so it's really giving a bunch of cushion between the femur and the tibia. When you lock your knees, like I said earlier, you're jamming these menisci in between the bone of the femur and the bone of the tibia, and they give a ton of stability into the knee. We've got a bunch of ligaments in the knee as well. So here we have the, everybody's heard of the ACL. The ACL is the anterior cruciate ligament. The PCL is the posterior cruciate ligament. So this is the PCL, which is going from anterior on the femur to posterior on the tibia. And the ACL, which is, I'll do it in a different color. The ACL, which you see back here, is going from the posterior femur to the anterior tibia. So if you were going to test these ligaments, which is something that we were going to do in lab together, to test the ACL, you'd have your patient sitting. You would hold onto their patella, put your hand over their kneecap, and then you would put one hand behind the tibia, and you would pull the tibia toward you and assess for the amount of mobility that you have within that joint. So is your tibia nice and firm, you can't really move it? Or when you pull your tibia out, does it come out an inch? Which is terrible, shouldn't do that. If you've torn your ACL, you can pull that tibia right out, which is very unsettling. To test the PCL, you're going to hold at the patella, and then you're going to make like a horseshoe, a U shape with your hands, and you're going to push the tibia from anterior to posterior, and that's going to test the posterior cruciate ligament. So if you have torn the PCL, you could test the ACL and that would feel fine, and then you would push back on the tibia and it would just keep going. It wouldn't have that end feel that you're looking for. Either way, you definitely don't want to tear the ligaments in your knees. The other ligaments that we have in this picture, we've got the collateral ligaments. So we've got Often they're called medial collateral and lateral collateral. Here we have called them the tibial collateral because the tibial collateral is the medial side, and the fibular collateral is the lateral collateral ligament. So that would be MCL and LCL. So you may have heard people tearing those before. Those are giving lateral stability to the knee, which is very important. All right, so we're going to go over those again. So we have 7 ligaments that are associated with the knee joint. The patellar ligament, which you can see here, connects the base of the patella to the tibia. Remember, ligaments are attaching bone to bone. So the patella is within the quadriceps tendon. Remember, sesamoid bones are, they grow within a tendon. So above the patella, we have the quadriceps tendon, which goes into the quadriceps muscle, which is here, 4 muscles. And so above it, we have the quadriceps tendon, and then below the patella, connecting bone to bone, is the patellar ligament. The popliteal ligaments are on the posterior side. We'll look at those in a second. The ACL and PCL we just talked about. We're going to look at them again. Those are inside the joint capsule, so those are intracapsular. And I do want you to know what ligaments are intracapsular and or what structures are inside the capsule and what structures are outside the capsule. So the ACL and the PCL are intracapsular, they're inside the capsule. The patellar ligament, the popliteal ligaments, and the collateral ligaments are all extracapsular. So again, you can see the tibiocollateral ligament over on this side and the fibular collateral ligament over on that side. So this would be the medial collateral and the lateral collateral. And then we have this patellar retinaculum or retinaculae, which is just additional ligaments that are stabilizing the anterior knee and the patella into the tibia. Here's our posterior view. So we've got the popliteal ligaments. The popliteal ligaments are crisscrossing in the back of the knee, so they're giving nice rotational stability there. I think that's all we needed to look at on that slide. All right, and then we're going to talk about aging joints, and you'll find that we do this with most of our sections now that we're going one system at a time. We like to look at what happens to us as we age, because it's inevitable. Everybody's going to age, and we have a bunch of problems that can happen. So with aging joints, we have rheumatism, which is pain or stiffness in the skeletal system or the muscular system. So it's kind of a generalized term for I'm uncomfortable in these systems. Arthritis is considered all forms of rheumatism which damage articular cartilages in synovial joints. So what that means is that you've got that nice smooth hyaline cartilage covering of your joints at the of your bone surfaces at the joint, and that can get worn away as you age. There are a couple of different kinds of arthritis. Osteoarthritis is a wear and tear arthritis, which basically means like you beat yourself up and now you're kind of paying for it. Now you're, say you played professional football until you were 30, and then all of a sudden when you're 50, your cartilage is totally worn away in your knee is bone on bone, and you have to have your knee replaced. So that happens frequently. This slide in your book is going to say that osteoarthritis generally happens in people over age 60, but unfortunately these days we're seeing it in people who are younger and younger, even in some children, due to obesity. Obesity, carrying around a severe amount of weight, an excessive amount of weight, is really placing a big strain on your joints, on your muscles, on your cardiovascular system, everything. But it does give added stress to your joints, and so that can cause wear and tear, and we're seeing it more and more in younger people. Rheumatoid arthritis is a different kind of arthritis. It's an inflammatory condition, which is often an autoimmune condition. Autoimmune diseases are where your body's immune system start attacking your own cells. So typically the cells of the immune system are looking for antigens on specific cells that are not present in your body. So it can look at that and say, hey, that's not normal. I'm going to attack it and kill it because I don't want it in my body. But in autoimmune disorders, your immune system sees a normal cell and thinks that it's not right. And so it goes and it attacks that normal cell. And so in rheumatoid arthritis, the cells are attacking connective tissues in the body. So those connective tissues are cartilage, any bone, collagen fibers, all of those different things. It can also affect your heart because you have all these connective tissues around your heart. There's a lot of different things that can happen with rheumatoid arthritis. Psoriatic arthritis is another condition that is very similar to rheumatoid arthritis. It develops in people who have psoriasis. In probably, I think it's about 10% of people who have psoriasis end up with this psoriatic arthritis, but it is an inflammatory autoimmune disease, and that's usually treated with traditionally you're going to start with like a methotrexate or a Plaquenil. Those are oral medications. And then you can move on to the disease-modifying anti-rheumatic drugs, or the DMARDs, which would be Enbrel, Humira, all of those different things that you see commercials for on TV are those rheumatoid arthritis and psoriatic arthritis, and ankylosing spondylitis is another one, medications. And then there's gouty arthritis, which is when you have uric acid crystals that build up within the synovial fluid, and that is severely painful. If you think of having like little pin cushions in your joints and trying to walk around, that's what that feels like from what I understand. With gout, I was taught that when a lot of times it flares up in the great toe, and I was taught that when you have a gouty exacerbation, the weight of a single sheet on your toe is unbearable because it is so painful. When we immobilize joints, it reduces the flow of the synovial fluid, and the synovial fluid needs to flow because it needs to bring nutrients and diffuse those nutrients into the cartilage. So if that's not happening for a period of time, the cartilage starts to break down, and you can end up developing early arthritis in that joint. So that's often treated with some type of continuous passive movement. When you're in a cast, you're in a cast. There's not a lot that you can do for it if you've got a broken bone, but they're more and more using as many flexible materials as they can to help you keep all the movement that you can keep. As we age, I think we talked about before, our bone mass is going to decrease, our bones are going to get weaker, we start to develop osteopenia, and that can further develop into osteoporosis. We increase our risk of hip fracture, dislocation, and pelvic fracture. And last time I looked at the statistics with elderly patients, if they were to fracture a hip, they are extremely, I can't remember what it was, but the statistic was staggering about how likely they were to pass away within 1 year after a hip fracture as compared to not fracturing their hip. So this is the end of our lecture for today. I would traditionally end this lecture by showing you that incredible top 10 sports injuries video. So I encourage you to Google that on your own. Make sure you're watching the crash course videos on joints, and remember, this is a short week, so go ahead and get your homework and your quiz done, and be ready for new material in a couple of days. All right, have a great week, and I'll see you guys in a few days.